Great. Well, thanks for the invite. Hopefully, you can all see my slides up there. So I'll I'll spend the next half hour or so giving a talk about HIV-associated cryptococcal meningitis and running through almost 2 decades of research now. So the talk will cover several aspects. I'll start by setting the scene with a bit of epidemiology. We'll then discuss the need for new treatments and talk about new treatments, primarily focusing on the Ambition trial, what led up to it, what the outcomes have been from that trial and the pathway to impact, and what we're doing next. And then if we've got time, we'll touch on preventing cryptococcal meningitis and talk about cryptococcal antigen screening. Feel free to interrupt at any point if things aren't clear or you've got questions, or also happy to take questions at the end. So in terms of setting the scene, I first started working on cryptococcal meningitis almost exactly 20 years ago now. Time flies. And I was based out in Cape Town, where I was doing my PhD, and I was working at Worcester Hospital. And at that time, Graham Menkes and Kevin Reby were running the infectious diseases unit there. And this was back when antiretroviral therapy rollout had just started in South Africa. This is what the UN AIDS estimates of AIDS-related deaths were looking like in South Africa. And at that point, HIV was the leading cause of mortality in South Africa, causing over 50% of all deaths. So you can imagine what we were seeing at Worcester Hospital at that time. And colleagues had looked at what people were actually dying of, and it was consistently three leading causes of death. And this has been replicated in studies from across Africa, and it still remains the case today. And those leading causes of death are bacterial infections, tuberculosis, and cryptococcal meningitis. So I'm sure you're all familiar with cryptococcal meningitis. You probably don't need much of a background, but it's caused by Cryptococcus neoformans, or less frequently Cryptococcus gattii. This is a yeast, a budding yeast, which is around us in the environment. We're all exposed to this. We breathe this in, it gets into our lungs. But in most cases, once it gets into the lungs, it will be either cleared completely immediately by your immune system, or it will be phagocytosed by an alveolar macrophage. That alveolar macrophage will call in some T cell help, and it will be walled off within a granuloma, much like tuberculosis is, and it'll sit there not causing any problems at all for the rest of your life. But if you have defects in your T cell mediated immunity, then that infection can reactivate, it can disseminate, and it gets into the bloodstream and has a particular predilection for the central nervous system for reasons that we're not totally sure about. But when it gets to the central nervous system, it causes a really severe, devastating meningoencephalitis, which is 100% fatal in the context of advanced immune suppression if it's not treated. So worldwide, the main risk factor for having defects in CD4 mediated T cell immunity is of course HIV. So HIV is by far and away still the most important risk factor for cryptococcal meningitis worldwide, and most of the crypto we see is in the context of advanced HIV disease, usually with CD4 counts of below 100. Back in 2005, 2006, when I first came to Cape Town, the global epidemiology of Cryptococcus was really not very well understood. It was clear to clinicians working at the coalface that this was a very common infection, but the absolute number of cases and where it sat in terms of the burden of mortality was not really known. Treatment at that time was generally with oral fluconazole monotherapy at doses of 200 to 400 milligrams. And the outcomes with that treatment were really terrible. Acute mortality rates ranging from 60 to 90%. And there were no widely implemented prevention strategies. So with a large collaborative team, and a few other groups in the world have been looking at this as well, research was undertaken to define the epidemiology to improve treatments so that we could improve patient outcomes and try and develop and implement some prevention tools and strategies to stop people getting crypto in the first place. In terms of epidemiology, this was the first paper we published from Worcester Hospital on the epidemiology of Cryptococcus. This was looking back at about 5,000 lumbar punctures done at Worcester Hospital over several years, looking at just the routine laboratory diagnosis, what was being diagnosed in people coming in with suspected meningitis to the hospital. And of those cases, in about half, there was either a microbiological diagnosis or they had markedly abnormal CSF with raised cell counts and abnormal protein and glucose. And if we look at the breakdown in microbiological diagnosis, you can see that cryptococcal meningitis was by far the most commonly diagnosed cause of meningitis. We got a microbiological diagnosis in about half of those who clearly had abnormal CSF. In the other half, in whom we didn't get a diagnosis, I suspect that TB was being underdiagnosed, but you could see that even accounting for that, overall crypto was causing the majority really of adult meningitis in that setting. And these findings have been replicated elsewhere, and global burden of disease estimates have subsequently been produced, suggesting that currently cryptococcal meningitis is causing somewhere in the region of 150 to 200,000 deaths a year. Nearly all of those are in sub-Saharan Africa in high HIV prevalence settings. And if you work out what proportion of all HIV-related deaths globally that is, it's about 20% of all HIV-related deaths globally are being caused by cryptococcal meningitis. These are global burden of disease estimates that were last updated in about 2019. Actually, that's slightly out of date, that slide. And this map is just showing, I think, what you would expect. The burden of disease closely maps where the burden of HIV is. So in high HIV prevalent settings, we tend to see a high prevalence of cryptococcal meningitis. Now, it's worth just taking a bit of a diversion here to think about, well, that's all good and well, but in the ART era, we shouldn't really be seeing much advanced HIV disease. And if we're not seeing much advanced HIV disease, we shouldn't be seeing much cryptococcal meningitis. But unfortunately, we do still see a lot of advanced HIV disease. And there are several reasons for this. Advanced HIV disease has become a bit of a neglected issue in terms of global health policy and planning. As the HIV treatment pendulum has swung from when we started doing this work in South Africa in the early 2000s, we were waiting until people had a CD4 count of 200 before we even started antiretroviral therapy. And of course, that's changed to 350, 500, and then in 2015, treat all. And the need for having a baseline CD4 count to determine treatment eligibility disappeared. People stopped worrying about CD4 count so much and started focusing on HIV testing, rapid initiation of treatment, and virological suppression. And the expectation was that as that happened, the number of people with advanced HIV disease would really shrink very rapidly. The number of HIV-associated deaths would shrink rapidly, and we wouldn't be seeing this as a problem. But unfortunately, that's not the case. It hasn't disappeared. One of the reasons is this is the last or most recent global data looking at CD4 count at the time of ART initiation. And if you look at CD4 count at ART initiation, it's fairly consistent. It's the same across nearly all global regions. About a third of people have advanced HIV disease when they start antiretroviral therapy. So late initiation of ART is still quite prevalent. That is compounded by the fact that we're not really doing CD4 counts in many places anymore. So these are some data from Uganda, looking at the proportion of people who had a baseline CD4 count before and after the introduction of treat all policies in 2017, when the need for CD4 counting for treatment initiation stopped. And you can see this absolutely catastrophic decline in baseline CD4 testing. So this third of individuals who have advanced HIV disease at baseline are not being identified a lot of the time. And this is mirrored again in the global data. If you look in Africa, excluding South Africa, which is a bit better, fortunately, but excluding South Africa, CD4 count measurement at ART start declined from 54% to just 16% across sub-Saharan Africa as a whole. So over 80% of people starting ART are not even getting a CD4 count, meaning we can't identify advanced disease anymore. But that's not really the biggest problem anymore. So when we look at our cryptococcal meningitis cases, the vast number of them are not people new to care or people who haven't started ART. They're people who've been diagnosed and been started on treatment, and they've cycled in and out of care. And the care cascade is not a linear cascade. People don't just get diagnosed, start treatment, virally suppress, end of story. There's much more complexity than that. People cycle in and out of care. And this has been, I think, underplayed or ignored in large part, certainly in the data that we report back and that UNAIDS reports out, showing these 98% viral suppression rates, which of course imply that you've got at least 98% retention in care and adherence rates. But that's not what we're seeing. These are some data from Western Cape, so from where you are, from the provincial data set there. And what Claire and colleagues did was look at a cohort of about 70,000 individuals initiating antiretroviral therapy, and they looked at the cumulative incidence of treatment interruptions, and they found a 71% cumulative incidence of treatment interruptions. In other words, that within the first 5 years of treatment, over 70% had interrupted their ART at least once. And these interruptions were not short. The median duration was 7 months. That's plenty of time for CD4 counts to rapidly decline, for viral loads to go up. And of course, that has huge implications for advanced HIV disease and for how many people are going to be presenting with opportunistic infections like crypto. And this isn't just in South Africa. These are some data published last week from Zambia. This is a cohort of over 160,000 ART initiators. And in this cohort, only 51% of clients initiating ART between 2018 and 2022 at Zambian facilities remained continuously engaged in care. By 6 months, only 34% at 12 months. So really a huge issue with retention and with people cycling in and out of care. And if we don't deal with this, we're not going to deal with advanced HIV disease. And if we don't deal with advanced HIV disease, we're still going to have lots of people dying of cryptococcal meningitis. So having set the scene, let's focus a bit on cryptococcal meningitis and the need for new treatments. So this is basic stuff that you'll all be fully aware of. Cryptococcal meningitis, really 100% fatal if left untreated. I'd mentioned that treatment across much of Africa back in the early 2000s with oral fluconazole. Unfortunately, that still remains the case in quite a number of settings across the African continent and in various other low and middle income country settings. And mortality outcomes with fluconazole really suboptimal. Amphotericin B deoxycholate, the injectable antifungal agent with activity against Cryptococcus that until recently was the only one really available across most settings, was more effective, about 40 to 45% mortality in clinical trial settings at 10 weeks, so an improvement from that 60 to 90%, but still inadequate, but also very difficult to give. Amphotericin B deoxycholate is a toxic drug. It causes severe thrombophlebitis. You need to be inserting drips every day in the conventional courses for up to 14 days. It causes renal impairment. It causes anemia. It's a difficult thing to do, and particularly in remote and rural hospitals or hospitals that don't have the resources available for toxicity monitoring or much in the way of nursing care. So there was really a need to define new treatments for cryptococcal meningitis that could be given in lower resource settings. They could be given easily by stretched healthcare facilities and staff, but would be highly effective. So I'll just talk you through a few of the trials that were done, many of these in Cape Town, by a big collaborating team there. And the first studies there were a series of phase 2 studies where we used a surrogate endpoint of the rate of clearance of Cryptococcus from the CSF as the trial endpoint. And the way we did that was we undertook serial lumbar punctures here. Some of you in the room may recognize the person in this slide, Tihana Bikinic, who first came to Cape Town in 2005 and set up several of these phase 2 clinical trials. There's Tihana doing a lumbar puncture. These lumbar punctures were done at baseline, at day 3 and at day 7 during the treatment of people with cryptococcal meningitis. The CSF was taken to the lab and then it was diluted in a series of 10-fold dilutions. And each of these dilutions was plated out on some Sabdex agar in a set quantity of 100 microliters on each side of the plate, and then incubated at 30 degrees for a couple of days. And you start to see these colonies growing. And you can choose the dilution where you've got distinct colonies, count the number of colonies growing, and you can work out by multiplying up by the dilution how many colony forming units per mil of CSF there are. That gives you a very accurate indication of the fungal burden at the site of infection in the central nervous system. And by looking at this over time, we could plot how rapidly an individual is clearing their cryptococcus. Each line on this graph indicates the clearance in an individual, looking at how fast they're clearing their cryptococcus. And of course, what you want is a very fast clearance of cryptococcus from the CSF. And the first study that Tiana and Graham and colleagues did at Worcester Hospital was looking at people who were receiving oral fluconazole, as many people still were at that time, versus amphotericin B deoxycholate, the injectable treatment that was just being rolled out. And you can see a huge difference here, even though it's a small number of patients. It's obvious from the back of the room. You don't really need statistical tests here to tell you that fluconazole just isn't clearing the infection from the CSF, whereas amphotericin B is, and much more rapidly. With ampho treatment, by 2 weeks, most people were on the way to clearing the infection completely. About half were culture negative by day 14. With fluconazole, none of the patients had cleared. In fact, the organism burdens were staying almost constant. And this was reflected in the fact that many people were dying with fluconazole treatment with those high mortality rates. And when we went on to start antiretroviral therapy, many people were getting severe immune reconstitution reactions because their organism burden was still very high when we were reconstituting their CD4 counts and immunity with ART. We also saw big problems with the development of secondary fluconazole resistance. So because of this high organism burden over time in the presence of the drug, the Cryptococcus mutated quite rapidly to become resistant to fluconazole, and we saw quite a lot of drug-resistant disease, which we just don't see anymore. So that showed really why we shouldn't be using fluconazole monotherapy and why amphotericin B would be superior. These were some studies done in Uganda looking at whether increasing the dose of fluconazole would help, increasing from 2 to 4 to 8 to 1200. And you see that as you increase fluconazole dosing, you do start to see an increase in the early fungicidal activity, the EFA, the rate of clearance of infection here. Seemed to be optimal with a fluconazole dose of about 1200 milligrams, which is why that's the standard fluconazole dose for cryptococcal treatment in combinations now, but still a long way off what we need, a long way off what we were seeing with with amphotericin-based treatments, and still 54% mortality, so not ideal. These are some studies done in Malawi using the same technique, but now saying, well, we've increased the dose of fluconazole up to 1200. How about adding in some flucytosine? What impact would that have? And the impact was quite a major impact. You see that that really improved the clearance of infection. The rate of clearance now is starting to approach that we see with amphotericin. Not quite, but it's getting there. So flucytosine obviously has a major impact on fungal clearance. Again, an improvement in mortality. We're now starting to see mortality rates with that oral treatment of fluconazole and flucytosine that were similar to the mortality rates we're seeing with standard treatment courses of amphotericin B deoxycholate used as monotherapy. So we're getting an oral regimen which is starting to approach the efficacy of an intravenous regimen, still not good enough. So if oral regimens don't seem to be ideal, what about amphotericin B? Well, as I mentioned, it's toxic, it's difficult to administer in resource-limited settings. Thrombophlebitis is very common. This is a picture of a chemical thrombophlebitis, a big red stripe going up that person's arm from the drip. And these drips tissue, they get secondary bacterial infections. We saw nosocomial sepsis in about 15% of individuals getting 2 weeks of amphotericin B deoxycholate treatment for cryptococcal meningitis. Infusion reactions. The anemia is not trivial, a mean 2.3 gram per deciliter drop over 14 days. So if you're starting with a hemoglobin of 6 or 7, that's a very clinically meaningful drop in hemoglobin, which has impacts on mortality, renal impairment, potassium and magnesium wasting. It's tricky. What could we do to improve that and make it more feasible? Well, one possibility would be to give shorter courses of amphotericin B deoxycholate. And there were animal model data suggesting that that could or should be feasible and should work. So this is a rabbit model of cryptococcal meningitis, looking at giving just 3 days of amphotericin B deoxycholate versus the standard daily 14 days. The graphs at the top show the fungal burdens in the CSF of the rabbits and how they decline over time. And you can see that it's almost the same with just 3 doses as those daily doses. And if you looked at the fungal burden in the brains of rabbits at the end of the treatment course, you can see that you got about the same decline in fungal burden with very short courses. And that would, of course, have toxicity benefits. You'd avoid some of the toxicity by shortening the course of amphotericin B deoxycholate. So that's what Tom Harrison and Sheila Malloy and colleagues across several East African sites did in the ACTA trial, which was published in 2017. And the ACTA trial was a bit of a complicated trial. I'll just talk you through this figure. So the primary comparison was between the standard 2-week course of amphotericin B deoxycholate and a shorter 1-week course. But as well as doing that comparison of the short 1-week course versus a 2-week course, they wanted to look at which partner drug should be given with amphotericin. So they also gave either fluconazole or flucytosine as the partner drug in each of those arms. So that meant you had 4 arms. You had 1 week with fluconazole, 1 week with flucytosine, 2 weeks with fluconazole, and 2 weeks with flucytosine. And they also included a 5th arm, which was an all-oral arm with fluconazole and flucytosine. And the bottom line is shown here. The primary outcome was mortality to 10 weeks. This was about 600 patients randomized into the trial. And the best performing arm is there in the first red box, and it was 1 week of amphotericin B with flucytosine, 24% 10-week mortality. So by far the best mortality outcome we'd ever seen in a trial in cryptococcal meningitis. And interestingly, much, much better than 2 weeks of the same treatment regimen. So that sounds a bit counterintuitive. How are you getting better outcomes with just 1 week versus 2 weeks of the same treatment? And the answer is that when we looked at the rate of clearance of infection in this trial, the rate of clearance of the cryptococcus from the CSF was exactly the same in the 1 week and the 2 week arms, which is what we would have expected based on the animal model data. But the toxicity was substantially less. So much of that excess mortality in the 2-week arm is probably related to drug toxicity and the complications of giving 2 weeks of that therapy. So we're getting the clearance of infection we need, but we're avoiding the associated toxicity. Now, what's also interesting to note here is that to get that efficacy at 1 week, it's essential that you have a good partner drug, and that's given with flucytosine. If you look to the left of that 1 week amphotericin B and flucytosine box to the 1 week of ampho given with fluconazole, you see that the mortality was almost 50%. So in order to use these short abbreviated courses of amphotericin, you have to be giving a fungicidal partner drug, and flucytosine is currently the only drug we have to do that. Interestingly, the oral arm was actually the second best performing arm in this trial. So if you're really stuck and can't give intravenous therapy, high-dose fluconazole and flucytosine, although not optimal, is actually better than any of the other intravenous regimens in the ACTA trial. So all of this research has led to practice changes and guideline changes in how we manage cryptococcal meningitis. So you've seen those data showing that amphotericin is clearly superior to fluconazole. Some of the early studies in Cape Town defined the dose of amphotericin B-deoxycholate, showing that 1 milligram per kilogram was better than 0.7 milligrams per kilogram. The ACTA trial and some other studies from Vietnam really defined flucytosine as the optimal partner drug, and that 1 week of amphotericin plus flucytosine was better than 2 weeks. And this reflected in how cryptococcal meningitis guidelines and treatment has evolved in South Africa with the switch from fluconazole to amphotericin, and in 2018, the introduction of flucytosine. And this has had real-world impact. So these are data from the NHLS in Johannesburg, the NICD and Nelish Govender and team, looking at what happened when flucytosine was rolled out in South Africa, and they compared people who'd received amphotericin B with fluconazole to those who received amphotericin B with flucytosine. And what you saw was that mortality was reduced by 53%, relatively reduced by 53% in individuals receiving flucytosine versus fluconazole. 24% mortality, very similar to that seen in the studies, although this was at a slightly earlier time point, versus 37% in those with amphotericin B-deoxycholate and fluconazole, again, very similar to that seen in the studies. So those study findings are translating into real-world findings. And this routine data, I think, really highlights the importance of making sure that your patients are getting flucytosine when you're treating them for crypto, because that is a really big difference. You don't have to treat many people with flucytosine to save a life. But all fine, we're still having to deal with amphotericin B-deoxycholate in this treatment regimen, which is, as we've seen, toxic, difficult to administer. We're still having to give at least 7 days of therapy. What about liposomal amphotericin or AmBisome? We know that that's much less toxic. That's the standard formulation of amphotericin that will be used in the States and Europe. It's got a very long tissue half-life, so theoretically giving large bolus doses or short courses should be effective, and it gets into the central nervous system very well. So all in all, it really sounds like it would be ideal for treating cryptococcal meningitis. And that is what led on to the AMBITION trial. So I'll run through this next trial now, the AMBITION trial, where what we wanted to do was really define, well, how do we best use liposomal amphotericin B in the treatment of cryptococcal meningitis? Its use had been limited to this point by the fact that if you gave standard 3 mg per kg or 4 mg per kg doses over 14 days, the cost was absolutely astronomical. It was about $5,000 a treatment course compared to about $12 per treatment course for standard amphotericin B-deoxycholate. Clearly not feasible. But we hoped that if we could get away with giving just a very short course, much less drug overall, and try and negotiate some preferential pricing, this might be a cost-effective option. So the first phase 2 study was using our rate of clearance of infection endpoint. We looked at a control arm, which was 14 days of standard dosing versus a single high dose of 10 milligrams per kilogram on day 1, 2 high doses, day 1 and day 3, or 3 high doses, day 1, day 3, and day 7. Primary outcome was the rate of clearance of infection. The graphs are shown there, and the bottom line figures are in red. And the more negative that number, the faster the clearance of infection. And you can see that we did very well with the high dose single dose arm in terms of rate of clearance of infection. This was designed as a non-inferiority trial, and the box in red shows the point estimates for the difference in clearance between 3 doses in control at the top, 2 doses in control at the middle, single dose and control at the bottom. And it shows you that all 3 short course treatments were non-inferior in terms of rate of clearance of infection to control. It shows you that there was no clear dose response at all. It looked like giving a single dose had maximal antifungal efficacy. Giving a second or a third dose really made no further impact. And the point estimates are all actually in favor of the high dose short course treatment, suggesting that you might get even faster clearance of infection with that really high bolus dose up front compared to just standard dosing. So that laid the scene for the phase 3 ambition trial. We knew from the ACTA trial that 7-day courses of amphotericin could be given, and that flucytosine was an essential partner drug. We knew from our phase 2 study that the best way of giving the liposomal ampho seemed to be a single 10 milligram per kilogram daily bolus dose. So we designed this study following on from those 2 pieces of work, and what we compared was a single intravenous infusion of high-dose liposomal ampho, 10 milligrams per kilogram, given with fluconazole and flucytosine, based on the ACTA trial data showing how important flucytosine was, to what was then the World Health Organization standard treatment, which was 1 week of amphotericin B-deoxycholate with flucytosine followed by fluconazole. The study was done in Cape Town at Mitchell's Plain and Kailicha and several other sites in 5 other African countries. And we published this in 2022, so a few years ago now. And the primary mortality endpoint, 10-week mortality, is shown there in the top graph. And you can see that 10-week mortality was actually lower in the single-dose ambisome arm than the control arm. It met our predefined non-inferiority criteria, and in adjusted analysis actually just reached superiority. And it was significantly easier to give. Both patients and healthcare providers preferred this regimen, and it was significantly safer with far fewer grade 3 or 4 adverse events, in particular much lower rates of anemia. So that was very quickly taken up around the world. It was, after the initial conference presentation, promoted on quite a few websites. MSF made the point that for this to be applicable and usable, the drug ambisome would have to be made affordable by its manufacturer, Gilead. And Gilead, the manufacturer, in response to that, announced preferential pricing for liposomal amphotericin for cryptococcal meningitis, bringing the price of a treatment course down from approximately $5,000 to about $160. So a massive change in price, which actually made this feasible and implementable. And this trial and these data led to WHO changing international guidelines very rapidly in 2022. And nearly all of the countries where the study had been done, as well as many other studies in Southeast Asia and Latin America, as well as Africa, moved to using the ambition regimen as their first-line treatment. South Africa was a bit of a lagging country for various reasons, some of them to do with ambisome procurement in the country. But this year, finally, it has been approved for use and will become the first-line recommended therapy in South Africa. And I'll be interested to hear actually whether you've got access to liposomal ampho and flucytosine in Cape Town. In Gauteng, in most of the big academic hospitals there, they're starting to use this regimen for treatment of crypto, but I'm not sure how widely it's distributed yet in South Africa. And this stimulated a bit of interest again from the patient groups and activists about trying to get more access to these life-saving treatments and make sure that people weren't forgetting about advanced HIV disease after a long time of HIV conferences and the global HIV community to some extent ignoring this as a problem. So in the next 10 minutes or so of the talk, sorry, can I just check, Fiona, how am I doing for time? When do I need to finish?
You're doing very well. We have about 20 minutes still.
Okay, fine. So I'll try and leave plenty of room for questions at the end, but let me just run through these next slides. So in many diseases, if we'd done a trial that had a 24% mortality at 10 weeks, we wouldn't be viewing that as a huge success. And it's still too high. It still means that too many people are dying from cryptococcal infection. So I think we still need to try and work out strategies to reduce mortality from this disease and stop so many people dying from it. So what could we do? Well, potential approaches are novel antifungal agents and new antifungal therapies. I think we've optimized the dosing and use of the current antifungal agents that we have, so it will require some new medicines. Host-directed therapies and immune adjunctive treatment, I think, is an area of potential interest. And we may be able to develop more tailored and risk stratified approaches to treatment. So I'll just talk through each of those briefly. In terms of new medicines, what's in the pipeline? Well, one thing that's happening is the development of new formulations of flucytosine. At the moment, that has to be taken 4 times a day, which is very hard to do in many hospital settings. Getting 4 drug rounds a day in and getting that medicine into the patients is a huge challenge. If we could get something that could be given just twice a day during working hours, that may be much easier. And with DNDi as partners, a team at St. George's and in Malawi are working on a new formulation of flucytosine that could be given twice a day. That would make giving the existing treatment regimens easier, but wouldn't really, I think, wouldn't be expected to improve outcomes necessarily, but it will be very helpful. In terms of improving outcomes, I think that there's only really one antifungal agent on the horizon that looks like it truly has the potential to do that. And this is this drug. It's part of a group of novel antifungal agents that targets GWT1 protein. There's something called APX001 has become fosmanogepix, which is now a marketed drug. Pfizer bought that. But this product, the APX2039 in a rabbit model, looks like it's highly active against cryptococcal disease. So this is looking at the rate of clearance of infection from the CSF of rabbits. The gold line is amphotericin B, which until now has been the most fungicidal drug we've had by far. And you can see that this new compound, APX2039, is massively outperforming amphotericin in terms of clearance in this rabbit model. So it really looks like it could be a bit of a game changer in the treatment of cryptococcal meningitis, particularly if it was available as an oral compound. So this is now being the first stages of development are underway through a fail-safe grant award that we're part of with the University of Exeter and Liverpool. And in the next few years, hopefully we'll have some data on this. In terms of host-directed therapy, we've tried steroids. It didn't work. In fact, it made it worse. Dexamethasone in the CryptoDex trial significantly increased the rates of adverse events, significantly increased disability, significantly slowed the rate of clearance of infection, and there was a trend towards increased mortality. So that really was enough to definitively say that in the treatment of HIV-associated cryptococcal meningitis, at first presentation, dexamethasone definitely does not work. And in fact, that's based on the immunology, perhaps not surprising, because what we've seen in our studies is that your inflammatory response and the amount of inflammation you have is actually closely correlated with good outcomes. The more of an inflammatory response you have in cryptococcal meningitis, the faster your clearance of infection and the lower your mortality. So unlike in some other contexts like bacterial or TB meningitis in people without HIV, in the context of HIV-associated crypto, you probably want some inflammation to help clear that infection. And what I was doing, one of my studies in Cape Town when I was first there, was a study looking at adjunctive interferon gamma. It can be given as a subcutaneous injection. We gave it twice a day on day 1 and day 3, and showed that giving interferon gamma actually markedly increased the rate of clearance of infection in individuals with cryptococcal meningitis. This is yet to be tested in a phase 3 trial, but I think there's quite compelling reason to do it. We've now got even more data showing that your pro-inflammatory CSF cytokine response is clearly associated with the rate of clearance of infection and with improved survival. And we've also got really detailed transcriptomic data now from lots of our patients looking in depth at the immune response. And I think there are some other potential targets we could start looking at in terms of immune adjunctive therapy, including PD-1 blockade and some immunoglobulin or complement-directed therapies. So watch this space, nothing in the pipeline. What about risk stratification? Well, we've published a paper earlier this year showing that you can actually predict risk quite well with risk stratification tools in cryptococcal meningitis. And interestingly, when you look at the impact of the different treatment regimens based on the risk strata that the patient's in to begin with, you start to see how maybe we could target therapy. So for example, in the ACTA trial, that oral therapy, if you look at the green section of the graph, which is the third of patients with the lowest risk of mortality, you see that the oral treatment was basically as good as the intravenous treatment. Whereas if you look in the red patch of the graph, in those with a high risk of mortality, you see that the oral treatment really wasn't as good as the intravenous treatment. So you could imagine a situation where you can risk stratify people out, and those in the lower risk group you could be giving less intensive therapy to, and targeting intensive therapy to those at higher risk. But that hasn't yet happened. And finally, for the last couple of minutes, what about earlier diagnosis? So it would be best if we could prevent people from getting cryptococcal disease at all. We talked about the trajectory of cryptococcal disease from universal exposure to latency to CD4 declines. And you can see that as your CD4 count is declining and that cryptococcus is reactivating, cryptococcal antigen becomes detectable in the blood well before people develop meningitis. And could we intervene here? Well, the answer is yes, we could. There were very good cohort study data from Guletu and the Desmond Tutu HIV Foundation cohorts early in the HIV epidemic, showing that cryptococcal antigenemia was highly predictive of subsequent meningitis. We helped validate and develop the novel lateral flow assay, which is a very cheap and highly sensitive and specific test that can be used to test for cryptococcal disease. So that made the idea of cryptococcal antigen screening, where everybody who has a low CD4 count automatically gets screened for cryptococcus using this cryptococcal antigen test, feasible. And the WHO introduced this in their guidelines in 2011, subsequently again in 2018 with a high or strong recommendation. And in South Africa, this has been rolled out since 2016, when Nalesh and colleagues performed an evaluation in 2023. Over 1.6 million reflex CRAG tests had been performed in South Africa, about 100,000 CRAG positive individuals identified. So really potentially huge impact. The issue is twofold. One, we know that there are big problems in terms of implementation, in terms of getting those results back to patients and getting them onto fluconazole preemptive therapy. But also, it looks like fluconazole preemptive therapy alone isn't sufficient. So even with fluconazole preemptive therapy, people who are CRAG positive are at about 2 to 3-fold higher risk of dying than those who are CRAG negative. So I'm going to skip over this just in the interest of time, but basically we need to improve management of subclinical cryptococcal infection to reduce that mortality. One way is by trying to stratify people at risk, again using CRAG titers. There's a novel semi-quantitative cryptococcal antigen assay that could do that. And if you look at the prevalence of meningitis in asymptomatic CRAG positive individuals and mortality stratified by that semi-quantitative antigen titer status in the bottom panels, you can see that it's very closely related. So basically, if you're CRAG positive, but your MESQ titer is just 1, 2 plus, you're at very low risk of meningitis or dying. Whereas if you're 4 plus, you've almost certainly got meningitis and have a very high risk of mortality. So you could start to see how you might stratify management of CRAG positive individuals. So this is being looked at in several studies. And studies are also looking at trying to improve the treatment of that subclinical cryptococcal infection. At the moment, just using fluconazole monotherapy doesn't seem to be adequate, but the EFFECT trial is looking at the combination of fluconazole with flucytosine. That's almost completely recruited, and we'll probably have a result from that in the next 6 months or so. So that'll be the next big news, if you like, in cryptococcal management that may impact you. It's very hard to do a talk like this and not mention the fact that what's happening in the wider world is going to have a major impact. South Africa may be relatively protected compared to some places, but this major withdrawal in US government funding from PEPFAR and from the Global Fund is likely to substantially increase the amount of advanced HIV disease we're seeing around the world and increase mortality. This is a modeling study, just look at what we expect to happen, and it's millions of deaths over the next few years. And we already know that the impact on advanced HIV disease services and access to antifungal medications and cryptococcal antigen testing is really markedly declining across the African continent. And a lot of those hard-won gains are being lost. So we really need to keep up momentum, keep the policymakers feet to the fire, and make sure that governments are funding this properly. And I'll stop there. Lots of people to thank, and very happy to take questions for the last 10 minutes or so.